Welcome to the ISTH webinar series. I'm Caroline Cruz, President and CEO of the Platelet Disorder Support Association. PDSA was patient-founded in 1998 to educate and empower those with immune thrombocytopenia and other platelet disorders. Today, PDSA is a powerful force serving and unifying the global ITP community of patients, practitioners, caregivers, advocates, and key disease stakeholders. 2023 marked PDSA's 25th anniversary. PDSA is proud to partner with ISTH and the France Foundation on today's webinar, Treating ITP, Working Together to Improve Outcomes. Our presenters are PDSA medical advisors, Dr. Terry Gernsheimer, Professor of Hematology, University of Washington, and Dr. David Kuter, Chief of Hematology at Massachusetts General Hospital. Also joining us is Stephanie Sanford, Hematology Oncology Nurse Practitioner at North Shore Cancer Center. Moderating today's webinar is Dr. Nichola Cooper, also a PDSA medical advisor and hematologist at Imperial College Healthcare in London. I'd like to introduce you to her now. Dr. Cooper?
Hello, thank you very much. Thank you, Caroline, for the introduction. So the learning objectives for today are to demonstrate the understanding of the impact of chronic ITP in patients, outline for a patient the benefits and risks of current treatment approaches, and address common patient concerns regarding emerging ITP treatment options. So Caroline Cruz has welcomed us to the meeting. I will be discussing some knowledge check questions, and then we will discuss further. Terry Gernsheimer will discuss the true impact of ITP, Stephanie Sanford, the current approaches to managing ITP, and Dave Kuter, navigating advances in the therapeutic management of persistent or chronic ITP. We have some key takeaways from Professor Kuter, and then we'll be having a question and answer session at the end. Please do put your question and answers in the chat. So just a few questions. So if you use your QR code here, one question: which of the following is the most common clinical consequence for patients with ITP? Next slide. Question number 2: which of the following is considered a second-line treatment option for adults with persistent ITP? IVIG, prednisolone, platelet transfusions, or TPO receptor agonists? Question number 3: for ITP patients who are refractory to multiple agents and therefore concerned about the future treatment options, which of the following novel therapies appear to be most promising? Ultra-high doses of methylpred, stem cell transplantation, BTK inhibitors, or anti-CD38 on plasma cells? So I am now delighted to pass you on to Terry Gernsheimer.
Thank you very much, Nikki. And I'm going to discuss the true impact of ITP, what our patients have to teach us. And next slide, I'd like to first introduce Brenda, one of our ITP patients.
My overall experience of having ITP has included, the physical, which is the excessive nose bleeding, the bruising, the fatigue, and a lot of patients experience the fatigue because it is something else. It's really a major side effect of having ITP. And of course, I have experienced damage from taking the prednisone or the other steroids for all these years. I've ended up with frozen shoulders, and the last scan I had said I actually had necrosis, which is just the bones have been deteriorated in my shoulders and in my knees. So that's just the physical. The mental and the emotional struggles that I have had include always being worried about that platelet count. So mentally and emotionally, I've always worried about my platelet count. it's always in the back of your mind when you go to the doctor, because there have been some occasions when I've gone to the doctor thinking everything is okay, and it wasn't. And he would immediately put me in the hospital to get treatment. So I'm mentally drained thinking about what can happen, so many possibilities. As I age, I worry about falling and maybe hitting my head in some sort of way, and perhaps getting a brain bleed. I worry about just simple things like doing the dishes. And if a knife is in there, I wait until I'm finished and I put the knives in last if there are knives to be washed, because I don't want to cut myself accidentally. And that has happened before. So just day-to-day things can be mentally draining. And just one of the greatest things is just not having that energy to do the things that I want to do. And I don't want to be a hindrance to my family enjoying things, but there are times that we do go on trips, and I may have to, sit some things out because of the fatigue. But overall, I always think the positive and not let ITP have me.
I'm going to now discuss some of the pathophysiology of ITP. Early in the 1600s, ITP was recognized. There are actually drawings of purpura and petechiae in ITP, but it was not really understood, and that was why it was called idiopathic as opposed to immune, as to why the platelet count was low. Because once the possibility arose to be able to look at the bone marrow and understand that megakaryocytes were making platelets, it appeared they were plentiful. It wasn't until Dr. Harrington in the 1950s took what are called volunteers. Their voluntary status is questionable, considering that they were fellows, residents, and lab workers in his laboratory who volunteered to have blood from a patient with ITP infused IV, including himself. One has to say that he included himself in this experiment. And what you can see happened was within hours, the majority of these people dropped their platelet count significantly. This lowest line actually represents Dr. Harrington's platelet count, and they did recover over a number of days. But this was the first time that it was understood that there was something in the blood, in fact, the serum, and later to be seen in the globulin fraction of the serum, that was causing a destruction of the platelets themselves. And we began to understand that this was some autoimmune nature of what was ever circulating in the blood in the globulin section of the blood. Next slide, please. However, back in the early 80s, late 70s, 1970s, we began to have some other questions about what was actually happening. Excuse me. In our laboratory, Dr. Slister's laboratory, we began to do platelet kinetic studies where we were radio labeling platelets with chromium and radioactive indium to see exactly how long platelets that were autologous lived in the bloodstream. And we had an interesting finding, which was that indeed platelets did have a shortened lifespan, but perhaps not as short as we otherwise thought. And what would happen is that if we back calculated, it became obvious that not only was the platelet lifespan shortened, but these patients were not making as many platelets as they might otherwise have. What we were thinking, which was that there should have been an increased number of platelets coming out of the bone marrow, and indeed there were not. And so the question became, what was going on in the bone marrow to impair platelet production as well? Please click. what we began to understand is that, number one, there's a receptor on the megakaryocytes, the thrombopoietin or TPO receptor, that receives the signal to make more platelets. There's also a TPO receptor on platelets, however, and to some extent, the thrombopoietin was actually binding to the platelets that were being cleared, and if you will, throwing the baby out with the bathwater. But so there was not a stimulation on the megakaryocyte as one may have thought. But the other problem is that antiplatelet antibody binds to a similar target or the same target on megakaryocytes, thereby causing them to attack the megakaryocyte and destroy the megakaryocyte. And we understood this also from studies that were done in Dr. McMillan's laboratory and Dr. Nugent's laboratory that showed, number one, that platelets did not live as well or grow as well in culture if ITP sera was added. And also that by electron microscopy, we could see increased destruction of the platelets, increased apoptosis of the megakaryocytes when from patients with ITP. Next click, please. And so also antiplatelet lymphocytes or T cells caused direct destruction of the megakaryocyte. And so all of these things added together as a reason why there was impaired platelet production, as well as increased platelet destruction and decreased platelet lifespan. Next slide, please. So ITP has to be understood as a clinical diagnosis. We do not at this time have a reliable test, although we can measure antiplatelet antibodies. These are very difficult to get, and depending on the laboratory, they are more or less reliable and generally not recommended except in research settings to help diagnose clinical ITP. So we use clinical signs for that. The platelet count has to be low, less than 100,000, and there should be no other cause of thrombocytopenia that we can point out to. There are what we call primary ITP without any other cause that we can see of the thrombocytopenia, but also many secondary causes, which we do not call ITP. We call it a secondary ITP. For example, patients who have lupus, patients who have hepatitis. And so we make a distinction between those two, since there may be different types of therapy we may use. It's also important to understand as we go forward in this presentation that the staging system is there really for us to help understand therapies and compare these therapies specifically in clinical research, so that newly diagnosed and persistent ITP and chronic ITP, as we outline here, really makes sense in terms of how we are introducing into studies, but not necessarily a difference in pathophysiology. ITP patients, in order to make that diagnosis, should be responsive to either corticosteroids or IVIG and not have other cytopenias. And in fact, we generally will not put patient on a research study if they have not been previously responsive to corticosteroids or IVIG, which really should be, in most cases, considered the gold standard for diagnosis. Next slide, please. We are really understanding more recently what the incidence of ITP is. This study was done in the United States. I don't think there's much difference in the European studies either. There is a peak that occurs early on, decreasing in early adolescence, but then again increasing as patients begin to age, and specifically increasing after the age of 65 when more immune dysregulation becomes obvious. The other thing that was noted, we used to believe that ITP was really a disorder of young women, and although it appears that women do predominate in the ages 18 to 49, that's not true in the other age groups, and in fact, in older patients, there may be a somewhat small but noticeable male predominance. Next slide, please. We also note that ITP should not be considered necessarily a benign disorder. in fact, we know that although many patients do achieve a complete remission, and when we say complete remission, that does not mean off therapy, but are able to maintain safe platelet counts by the time that 6 months has gone by. But many patients do have persistently low platelet counts, and they have a 4 to 5-fold higher mortality risk over time, and an overall survival is reduced by approximately 5 years in patients who do have this persistently low platelet count. And in fact, in most patients, since some of the therapies that we use are fairly toxic, as our patient stated for us. Next slide, please. The majority of patients do present with some symptoms, although many of them are asymptomatic. Intracranial hemorrhage as a presenting symptom is relatively rare, but in studies done by Dr. Cooper, it has been shown that in patients who do have chronic ITP that has prolonged low platelet counts, although they may not have obvious intracranial hemorrhage, microhemorrhages of the brain can be documented. But many people do come in complaining of bruising, some of hemorrhage. But I think, as Brenda stated for us, one of the main things that we have heard from patients is this overwhelming fatigue. And indeed, some patients will tell us that they can tell when their platelet counts are low due to this sense of fatigue overall, which may be some manifestation of the inflammation associated with autoimmune disease. It's also interesting that approximately 8% of patients who have ITP have a history of thromboembolism in the past. Some of these patients are noted to have some cognitive dysfunction that has been shown in studies. And of adult patients who develop ITP, approximately 80% of them will go on to develop a chronic ITP that is lasting more than a year. Next slide, please. The other thing to note, as Brenda told us, is that patients with ITP do indeed have a lower quality of life. Although we don't have a good measure of exactly which quality of life scale we should be using for patients with ITP, you can see here that overall in the yellow bars, they have decreased physical function, even when compared to patients with arthritis or diabetes. They have bodily pain. Their general health, it has declined versus the general population, decreased vitality, decreased social functioning, as Brenda noted for us, and overall just a poorer quality of life, which I think is extremely important to talk to patients about. We may be more concerned about their bleeding and about their platelet count, but we really need to discuss with them, how is this affecting your life and what can we do to help with that, including what therapies might we alternate or choose for them to improve this quality of life, including what are their goals for therapy, what is their lifestyle, what are their jobs. Next slide, please. With that, I want to thank you. And I'd like to introduce Stephanie Sanford, who will now talk about current approaches to managing ITP. Stephanie?
Thank you, Dr. Gernsheimer. That was a lovely overview on the impact of ITP on our patients. So to discuss current approaches in managing ITP, we're going to work through a case study. So our case study here is Amanda. She's 27 years of age, a school teacher. She has a 4-year-old son, no significant medical history or medications. She shows up with general purpura, petechiae, frequent nosebleeds, and very heavy menstrual bleeding with a platelet count of 8. So as you can see here, some of her other labs are hemoglobin's 10, which is lower than normal, potentially because of her menstrual bleeding, and her white blood count and A and C are normal. So in terms of when someone comes in with an unexpectedly low platelet count, the most important thing to start with is checking a slide to see what's on there. So we have a smear here, and you can see her platelet count is confirmed here as quite low. You can only see one tiny platelet there in the middle right side of the screen there. Go ahead and slide. So our indications for treatment in ITP vary based on our platelet count and the patient themselves. So we don't treat everybody with ITP. If their platelets are between 20, 30,000, higher than that, without any bleeding or issues, we may watch them. But treatment might be indicated for patients with a platelet count as high as 50,000 if they're having other issues such as other trauma, surgery, other comorbidities for bleeding, if they've had a recent stent placement and have to be on antiplatelet therapy, or a profession like a professional hockey player or something like that that predisposes them to trauma. Slide. So when it comes to a new patient, typically they are understanding that or assuming that our treatment goal is going to be to get their platelet count back up to normal range, which is not true. What we want to do is prevent severe bleeding episodes and maintain a platelet goal, 30,000 for people who aren't bleeding, closer to 50,000 or higher for those who have additional risks. We want our treatment to have minimal toxicity in order to really improve and create as great healthcare related quality of life as possible. Slide. Our management options for first-line therapy are pretty standard. So often we start with corticosteroids. There's a preference for some for dexamethasone, other prednisone. If people are actively bleeding, oftentimes we start them pretty urgently with IVIG as well. Subsequent therapy, second line, with really good clinical trial data. We have thrombopoietin receptors agonists, fostamatinib, rituximab, splenectomy, which is so permanent that we often try to push that further down the line, as well as mycophenolate. As you can see here, there's also some potential further down the line therapy options with lesser clinical trial data. Slide. So on to Brenda giving us a little bit more information.
To the hospital, and at that time I was diagnosed with ITP. And I looked at them and said, "What?" And so they went on to explain that my body had destroyed all my platelets and that I would need medication. I stayed in the hospital for a week until my platelets came back up. They tried several different things and ended up using steroids, and the steroids seemed to make my platelets increase. After that, I was sent home with a very high dose of prednisone. The impacts of the early treatment was very, very harsh on my body. I ended up getting the big moon face. I had a hump on my back, a large stomach. The medication made my joints ache terribly, to the point where I was in so much pain that I was almost hysterical. The pain was just so much to bear. I was then starting the weaning process when all of this began to happen, and it seems like those conditions only got worse because I think my body was wanting those steroids at the same level. But as I was weaned off, over time, the issues got a little better. The side effects that I had were going away. My face was coming back to normal. My weight was coming back down, and I didn't have the urge to eat as much as I was eating.
So as we heard from Brenda, unfortunately, all therapies come with baggage here. So our benefits of corticosteroids here, they're cheap, they work quickly, but they have not only acute toxicities, patients can't sleep, they're irritable, get their glucose out of control. There's extended therapy, there's even more and more significant toxicities there. For immunoglobulins, we do get that rapid increase in platelet count, but they don't work for very long, and some people are allergic to them, and we can give headaches and infection risks with those as well. For our TPO receptor agonists, we can get good platelet response for a long time. We can improve the quality of life for some patients, but we have to continue watching not only their platelet count, but now their liver enzymes, and we can have some rebound thrombocytopenia. Additionally, not listed here is financial toxicity in terms of costs. Some patients can't afford these. Some of the insurance can be tricky to get through. Slide. We have rituximab therapy, which we can give out, and this can lead to actually some long-term remission off therapy in a significant amount of patients, but you can get prolonged lymphopenias and increased risk of infection with these. The fostamatinib benefits, it's a whole novel mechanism of action here. So patients who haven't responded to anything else, we have a little hope they can respond to this one. But it does come with side effects, diarrhea, hypertension, and potential for liver abnormalities. Splenectomy can also lead to long-term remission in patients, but unfortunately there's long and short-term risks of infection and thrombosis. So again, up to 60% of patients might get a long-term remission, but then you have 40% who relapse and still continue to have the concern for infection and thrombosis. Slide. So this clinical practice algorithm published in Blood, I will give a shout out to Dr. Gernsheimer and Dr. Kuter, who are on this paper to make up this clinical practice algorithm here for us. So what we see here is we start with the initial treatment, which is the corticosteroids. And typically we can get up to 80% or more response from that first steroid treatment that we give patients. Unfortunately, though, as we wean the steroids, we lose about 2/3 of patients end up relapsing during that taper. So we can move on then to TPO receptor agonists, which is also often what we're using for second line. We can capture about 85% of patients there in terms of good response ongoing. And then if we move down the line to an alternative TPO receptor agonist, fostamatinib or rituximab, we usually can catch another, 10%. So we're up to about 95% of patients that we can get a good response from some of these. Unfortunately, that still leaves a 5%, which is fairly significant of these, young patients who have now been through the line, up and down, in the hospital, bleeding issues. Again, a lot of these are young patients, young kids that have to, get childcare before they go to the emergency room. And now we're putting them on immunosuppressive drugs, immunomodulatory drugs that have less clinical trial evidence supporting them. So from there, we do have some clinical trials, and thankfully, more recently, we've had some promising ones. And then we usually leave that splenectomy for the final kicker there, again, just given the long-term complications, but I have seen that be effective in many patients. So slide. So for our initial treatment of ITP, as we've talked about so far, it's corticosteroids here. Again, IVIG, typically if we have acute bleeding. So prednisone or dexamethasone, and typically we want to see a response of platelets up to 50,000. That's our threshold. And we see that pretty quickly within a few days. If you see no response over an entire week, what we would do is just start tapering that and call that a treatment therapy failure. But if it does work and we get our platelets over 50,000, which many of our patients do, we're going to start tapering them and try to taper them over 6 weeks to avoid some of those long-term issues with steroids. Maximum 8 weeks. If we lose our platelet response in that 6 to 8 weeks during the taper, what we're typically going to do is start that second-line therapy. Slide. And what we do want to keep in mind in terms of the first-line therapy of steroids is there's really low long-term remission rates with these. A lot of people were able to get their platelets up quickly, first thing, but then we have to get them, but then as we get them off, which we have to, given the long-term toxicities, we lose that response. Slide. So when we start talking about therapy after corticosteroids, there are a lot of options. And I know this is an incredibly busy slide, but what I want to take home from this slide is that there's a lot of factors that come into play when we start thinking about second-line therapy and ongoing. So patient-related factors, there's external factors, we have treatment-related factors, and then also disease-related factors. So we've got to take that all into account while we're looking at our patient and seeing the platelets as well. Slide. So that leads us to talk about shared decision-making with our patients. So typically when we first meet a patient, they come in, they're bleeding, their platelet count's low, and they have, leukemia and some of these incredibly traumatic diseases on their minds. And so when we come to this conclusion of ITP, there's a sense of relief and then a sense of, doc, give me whatever you got, I'll do whatever you want, which is great. We have, good first line. We all know what we're going to be doing is those corticosteroids. But once we start getting into the second line, it's important that we're getting to know our patients and what they need, financial toxicities, childcare responsibilities, what their bleeding is, what other comorbidities they might have. But then equally important is that we're educating them of treatment down the road, what to look for, what the next steps might be, so that we can kind of get out of the driver's seat and be a co-pilot for them and helping them make these decisions for what best fits their life, because they're complex. And again, the slide shows there's multiple second line treatments, each with different benefits and risks. There's really not great trials comparing any of these things. And then patients are going to tolerate them differently. They have different schedules of how they're given. And so engaging your patients in that decision-making is going to improve their understanding, improve satisfaction with their care, and adherence to the treatment when we do come to a conclusion there. The PDSA does have some great patient focus and also clinician focused materials that help us facilitate this shared decision-making ongoing. Slide. So back to our case study with Amanda. So here she is. We did start her on 1 milligram per kilogram of prednisone, sent her home from the hospital. She returned 2 weeks later. Her purpura was improved, her petechiae was resolved, and surprise, she had insomnia. So there's those short-term side effects of the steroids. Her platelet count came up to 80,000, so that's above our 50,000 threshold. So we see we've got a good response from her, and thankfully her hemoglobin also came up, likely because the menstrual bleeding has stopped. So what is our next step? We have it answered right here for us. We're going to begin to taper her steroids. So we taper her steroids over 4 weeks, which brings us down to 20 milligrams daily for her from where she started. She comes into clinic this time, but with a 20,000. So her platelet count has dropped. Her purpura is still down, but now she has insomnia, she's gaining weight, she's getting her nosebleeds back, and her heavy menstrual flow is back. And so we're seeing her lose this response as we taper the steroids. Question becomes, $1 million question here, what are we going to do next? Slide. And the answer is talk to our patient. So we have some options for our next treatment. And it really depends if she places a high value on kind of having this ongoing durable response, taking a pill every day, versus if she wants to maybe kind of try a one-time shot, potentially with Rituxan, that she might be able to be off therapy for some time. Go ahead and just click for me. So what happens here is we're assessing our patient values and preferences. We're giving her the option of what the next step is going to be here. Slide.
Later on, around 2014, my doctor said that I had been on steroids for so long and he wanted to try a different medication. So he recommended an infusion of a drug called rituximab. With the infusion, I had to go once a week for 4 weeks, and the medicine was infused into my body. I had to get an IV and just stayed at the hospital all day because the treatment, they wanted to run it very slow. So I was there at least 6 to 8 hours. I chose Friday since it was the end of the week. And I didn't really have too many side effects from that medication. And it seemed to have a good effect on my platelets. They actually raised my platelets. And probably for the next, I would say, 18 to 24 months, when I would go in for my checkups, my platelets would be stable. Okay, so the rituximab worked about 2 years, and After then, my doctor wanted to try another steroid called dexamethasone. He said he had seen studies where patients had taken that drug maybe for 4 times, and after then, they wouldn't have any problems with their platelets. So I agreed to that and took the Dexa. And what I didn't know that it was a lot stronger than the other steroid that I had been given earlier in my diagnosis. So coming off the Dex, even though it was only 4 days at 10 milligrams each, once you came off of it, the effects from weaning off were terrible. They were much worse than the steroids. So after the second time of using that method, I asked my doctor if I could go back to the infusions.
So Brenda once again highlights the challenges in managing ITP here. Again, there's lack of evidence in general. Your doctor's kind of saying, well, let's try this, let's try that. The therapies that we do have limited efficacy, and then a lot of variable toxicity there. We have low long-term remission rates. We aren't very good at measuring and ongoing quality of life issues in patients, and we don't have a lot of biomarkers in terms of predicting which patients are going to respond to what treatments that we give them. It's very important that we assess our patient values and preferences. Again, when I heard Brenda the first time, I thought, oh, dexamethasone, it's such an easy 4 days and you're done. You know, that's something I like to give patients. Whereas for her, it was this horrible experience, right? And so to be able to have that back and forth of how things are affecting other people and not necessarily your perception. And that just allows for best shared decision-making. Slide. So back to our Amanda once more here. We decided to go with a TPA receptor agonist for her. So we started on oral trombopeg, 50 milligrams. Within 3 weeks, as we also were tapering the prednisone, 3 weeks, the platelet count did not rise. So we actually increased the dose from 50 to 75 milligrams. 6 weeks later, now her prednisone is completely weaned off. She's been on the 75 milligrams for 3 weeks. Her platelet count's still only 20,000. Fewer nosebleeds, but she's still having this heavy menstrual bleeding and fatigue. Hemoglobin stable, white blood count A and C are stable. But now we're seeing this not response to our first TPO antagonist. So the $1 million question becomes, what is the next step for Amanda? Slide. I'm going to leave that $1 million question in the great hands of Dr. David Kuter, who's going to be talking about navigating advancements in the therapeutic management of persistent and chronic ITP. Thanks, Dave.
Thanks, Stephanie. This patient, actually both patients, illustrate the fact that ITP is an interesting disease, and we're not fully there with therapies yet. And going back to our case here, she was discussed in terms of patient information education about splenectomy, and like most patients, I think rightly declined a splenectomy. She continued the L-trombopeg and then received a course of rituximab, which is the drug that Brenda got the 4 doses of. She comes back and her platelet counts 29,000. And the real question comes right now is, what do you do? And I'll be honest with you, in this particular case, at a platelet count of 29,000, if she's otherwise pretty well, I would probably do nothing more. But this is the kind of patient who might benefit from going on a clinical trial. So let me spend the last few minutes of our discourse today discussing what's in the pipeline. Next slide, please. So there are a lot of drugs being developed in ITP, and I'll describe the fact that they are usually developed in patients who are late in their disease course, not usually up front. There are molecules that inhibit the Syk kinase. There are things that inhibit the neonatal FC receptor called FcRn. There are things that inhibit a molecule called Bruton kinase, which are BTK inhibitors. There are drugs that attack a plasma cell, so acting on cells that make antibodies, which is an anti-CD38 approach, and one of them is called mezagitamab. Also daratumumab, which many of you know about, is also commonly used in ITP and is being studied. There are drugs that inhibit complements like sutimlimab. There are drugs that inhibit a B cell receptor called BAFF, and there's also molecules that are inhibiting a chemokine receptor. So there are clinical trials on all of these agents, plus a lot others, which I don't have time to go into. And I'm going to just spend the last few minutes of our discourse today discussing three of these, which is efgartigimod, which is a FcRn inhibitor, rilzabrutinib, and mezagitamab. Next slide, please. So when we talk about clinical trials in ITP, as I alluded to, we pretty much don't start with virgin patients in the emergency room. We start with patients who have typically failed other therapies. So for all the trials I'll discuss with you, the clinical trials for novel therapies usually include eligibility criteria is listed here, and I'm not going to read them all to you, but they include a confirmed diagnosis. Usually we want patients who have already responded to corticosteroids or IVIG, but have lost that response and are needing other therapies. We usually insist upon a platelet count in a threshold below 30,000. These are commonly adult patients, although clinical trials involving pediatrics are certainly being done and have been done. We want patients who are not actively critically ill requiring rescue therapy. We want to make certain patients don't have other causes for thrombocytopenia. We unfortunately, and I think this is the nature of most clinical trials, exclude pregnant patients or those breastfeeding. We certainly exclude patients with secondary causes of ITP, which is probably a quarter of all ITP patients. That probably is an area we need to reassess. We also insist patients not recently have had anti-B cell therapy or had their spleens taken out. Next. I'm going to start by talking about the neonatal Fc receptor. I'll talk briefly about its mechanism. On the left is an endothelial cell, and every day you imbibe about half of your total plasma volume. It goes into this thing called an endosome. You imbibe all kinds of proteins, including IgG. The endosome becomes acidified, and fortunately, the IgG binds to the red molecule here, which is a neonatal Fc receptor, and is protected. Other proteins are degraded, and then the endosome recirculates to the surface where the pH rises, and it releases the IgG into the circulation, giving it a half-life of 28 days. It and albumin are the two proteins in our circulation with that longevity. However, if you paralyze the neonatal Fc receptor, and that's the lovely blue antibody shown on the right side, it binds to the neonatal Fc receptor and inhibits it. And then when you imbibe the plasma, you then don't protect the pathologic, which are the red antibodies, or the normal antibodies in green, and they all get degraded. And then when the endosome recirculates to the surface, we've destroyed much of the IgG that's in the circulation. So this is a way to deplete the IgG concentration in the patient, but it decreases both pathologic and normal antibody. Next slide. In a recent study with a neonatal Fc inhibitor called efgartigimod, which is a molecule that in this study was given IV, which you can see on the gray bars is those that got placebo had no change in platelet count. Those that got the active molecule shown in the blue had a modest rise, an average of some 20 to 30,000 in their platelet count, and overall was shown on the right side of the slide, 22% of patients responded to this, whereas 5% of placebo patients responded. These are modest response rates, but you got to be careful. These are patients who have been multiply treated before and have what's referred to commonly as refractory disease. Next slide. A second approach is to recognize that when a platelet shown in the red at the upper left binds to a macrophage, which is the green receptors here, the antibody bound to the platelet causes the Fc receptor to bind the antibody and the platelet, and it imbibes and destroys the platelet and the antibody, as we demonstrated when Dr. Gernsheimer showed you that experiment from Dr. Harrington. When a macrophage starts to chew a platelet, as we're showing here, it requires a whole bunch of other molecules, one of which is Syk kinase, shown in the brown, another one called Bruton kinase in the blue here, and there are inhibitors that have been developed to both of these molecules that have activity in ITP. We're going to talk about rilzabrutinib, which inhibits Bruton kinase. We've already talked about fostamatinib, which inhibits Syk kinase, but there's a newer molecule called sovleplenib, which does that maybe a little bit more efficiently. Next. So the study that we have done with rilzabrutinib was given to patients with very late stage disease. We gave it to patients in a placebo fashion. We had placebo patients, which are shown in the diagram on the left, that had no response to the drug. Again, everyone got the active drug of 400 milligrams twice a day. There were responders shown the blue and non-responders shown the red, and 40% of patients increased their platelet count, oftentimes within a week of receiving the drug. And to our delight, the platelet count in the responders remained up. Indeed, the platelet count remained up over 50,000 for a median of 72% of the weeks on study. So the effect was early on very rapid, and it was very long-lived, and it was working in about 40% of patients. We can discuss later, if there's time, why some patients might have responded and others didn't. Next. The third molecule depends upon a very common protein on the surface of plasma cells and a wide variety of cells, which is called CD38. This is a very primitive enzyme that is a NADase, and it affects calcium flux in many cells, but it has evolved over millions of years to have immunologic function, to the point that, as you see on the right side of this slide, it plays a key role of interacting with a wide variety of other cells, such as NK cells and antigen-presenting cells and macrophages. So the way to think about anti-CD38, as the myeloma doctors in the audience might know, is it's on plasma cells, and the goal here is to have the antibody knock out the plasma cells and prevent antibody from being made. Next slide. When this was done with an experimental drug called TACT-079, and focus please only on the yellow bar here, at the highest dose, again, within 2 weeks, the median platelet count rose significantly to over 100,000. And if you follow the yellow bar across, for the next 16 weeks, these patients had a surprisingly high response rate. So up to 75% of patients had a response, again, rather rapid and indeed persistent. What's interesting about this is the response was rapid. The drug is supposed to work by decreasing IgG, but obviously it doesn't decrease IgG that fast. So there may be other mechanisms involved here, but this drug is entering clinical trials soon in a phase 3 study. Next slide. So I would love to talk for another couple hours on novel therapies for ITP, but I can't. And what I'm going to do is just briefly summarize what we've talked about this afternoon. I think the first important message is that ITP is a rather complex pathophysiology of inhibited megakaryocyte growth and platelet destruction. And those are the targets for most commonly currently available drugs and future drug therapies we're developing. Given the complex pathophysiology, there is a huge effort to develop new drugs in this area. Furthermore, from a clinical point of view, it's important to recognize that patients are not just the platelet count. Patients are not just at risk for bleeding, but of other symptoms of ITP, ranging from cognitive dysfunction to patients having troubles with fatigue. So when you talk to a patient, it's not just the platelet count that's important here, it's the other aspects of their ITP. When it comes to therapy, it's important to recognize that most patients with platelet counts with no risk factors down to 20,000 may not require therapy, but the vast majority of patients below that level and those with risk factors require a higher platelet count, and here's where treatment, initially corticosteroids or IVIG, works. And in that situation, the doctor is pretty much in charge in the emergency room of what the initial therapy is. But as the course of the disease goes on, and most patients who are adults require chronic therapy, it's important to involve your patients in these discussions as to what drugs they're going to be taking. And it's important to take their lifestyle consideration, activity, and have a mutual discussion with them in the disease case. This should happen throughout the disease course, but the shift to patients directing their care in a large way emanates in pretty much is important to include those patients once the initial therapies are involved. And finally, I think it's important to note that there is not yet a cure for ITP. We are currently focusing on treatments for ITP, but as we go along, our views are being shifted as can we cure this disease and make it disappear. On that, I'll stop and thank you.
And thank you so much. Thank you, everyone, for your amazing talk. So I think now we have some time for a question and answer. please do continue to put your question and answers into the question and answer section. So I have a few questions here already. So one big question is about fatigue, and there's a question here that says, fatigue in ITP patients without bleeding at all surprises me. Can you explain the biology behind fatigue in ITP, and does it have any relation to platelet count? And maybe Stephanie, could you, I mean, this is I guess it's interesting that not enough people know about fatigue in ITP.
Yeah, I can get started here, but I'd appreciate Dr. Gernsheimer and Dr. Kuter experience as well. So I have seen some patients that come in, again, instead of bleeding being their primary concern, with the fatigue being almost what presents them to come in first to repeat their CBC early. So I sometimes have seen that correlated, although I've seen people, where we even get their platelet count back up to where we want it. And I'm not sure, again, if the mechanism is inflammation or what, seems to continue that fatigue, kind of brain fog, that sort of thing can continue even when I get their platelet count under control.
Yeah, and Dave and Terry, do you have any thoughts about the cause of fatigue? What's the underlying pathology?
We've looked at this, looking at cytokines, assuming that it has something to do with cytokine levels. We've never been able to show that specifically there is a cytokine that's attached to that. I think certainly inflammation itself can cause some fatigue, although again, we don't really know which cytokines are the cause of that. But I have been very impressed that patients sometimes come to me and say, I know my platelet counts have fallen. There's questions about serotonin sink in platelets, but I don't think it's clear. David, do you have any comments about that?
Yeah, I'm going to say something maybe a little bit off target here, which is, 80% of patients going to a primary care doctor complain of fatigue. It's the most common complaint of all patients. And, I see patients with a wide variety of other hematologic disorders, and most of them are equally fatigued. But there certainly is an important aspect of ITP that many patients can say to you, hey, my platelet count's low because I feel fatigued. You measure the platelet count, it's low. Equally as I've given people therapy with a TPRA to raise their platelet count and their fatigue disappears. It's an amorphous and vague thing whose pathophysiology we don't yet quite know. There are studies underway, as Terry knows, that we're trying to do to generate some better information. It's, if you're a rheumatologist, this is half of your practice. It's the same kind of thing there. So I think it's all the inflammatory shtick that comes with this disease. But again, I can't focus on a molecule that does it.
And Dave, do you think any of the newer treatments might be more likely to treat the fatigue?
Well, if you come to our presentation on December 7th at ASH, we'll show a drug that does this. The rilzabrutinib drug may have a major effect upon fatigue, as our abstract we just released a couple days ago show. So there are medications that even complement inhibitors may also mitigate fatigue. So it may be affecting the cytokine storm that happens in these patients. But again, we're directing much of our focus towards that right now. So the answer is yes. Newer drugs may have that as a benefit in addition to raising the platelet count.
And okay, let's go to and see what other questions there are here. Another question is, if you don't respond to one TPO receptor agonist, should you switch to another, or should you go to a different treatment?
I can take that because we've published on that. And there's no question. We don't know why one TPO should work for a patient and another one should not. But because these drugs tend to be so effective, have a very good safety profile, we do sometimes, in a patient who hasn't responded, switch to one of the other TPO agents. Some of it may have to do with diet, some of it or absorption. So it is worth trying to switch TPO agents, and that does sometimes work.
But it may also do with potency of the agents, because these agents, the TPRs, vary enormously in terms of how potent they are in healthy volunteers in raising the platelet count.
And Stephanie, do you tend to switch between TPOs?
Yes, I echo what Dr. Gernsheimer said. We oftentimes switch and we'll see a response to the second line.
What about combining treatment? That's not a question on here, but do you often tend, for some of those difficult refractory kind of patients, do you combine treatments sometimes?
Terry and I use a cheaper drug called corticosteroids. So I just to preempt Terry's comments here, oftentimes when someone doesn't respond well to TPRA, adding 5 milligrams of prednisone makes them go from a non-responder to a responder. Likewise, adding a bit of dapsone sometimes does the same thing. I personally don't like combining therapies given the enormous costs, which are certainly prohibitive in other countries.
Which is why I like to just try 5 milligrams of prednisone, adding that to another drug, because it's so impressive how some patients suddenly become a responder. And most patients do tolerate that very small dose very, very well. If we have to get much beyond that, I think we need to look elsewhere.
I do remember being told off when I was a junior hematologist by one of my professors because I kept trying to get this patient off steroids. And every time I saw him, he'd drop his platelet count to 5. And he's like, 5 milligrams of pred, it's fine. Just keep him on it.
Right.
And sort of talking on steroids, so prednisolone versus dexamethasone, that's another question. Is there other patients from which who you think the dexamethasone is better than prednisolone? We heard nicely from Brenda that the dex made her feel unwell and sort of coming off it. So I was just wondering what everyone thought about dex versus pred.
I certainly avoid dexamethasone in older patients. It seems to be associated with a lot of side effects, particularly emotional side effects. I think the other thing to understand about this 4-day pulse is that I've seen a lot of patients after that full 4-day pulse crash their platelet count in between. And so I need to maintain them in between with some other corticosteroid, prednisone. And so I'm not really sure we get a lot of benefit out of using dex versus using something like prednisone or prednisolone.
Yeah,
And Dave, you have a dex.
Yeah, again, I'm not a dex fan, but I would simply say that if you compare dex to prednisone, the median platelet count rises maybe a day sooner with dex than with prednisone. And in resource limited countries, since we're talking to an international group here right now, I would think that in patients where in situations where IVIG is not readily available in a bad patient who's bleeding a lot, dex would be more appropriate than just prednisone. But given the side effects of prednisone and the relapses that Terry alluded to, I almost never use it.
And Stephanie, what's your thoughts on dex and pred?
It is nice to have the full 2 weeks, honestly, just in terms of then weaning them down. And when you're expecting so many patients not to respond or to lose that response with the weaning, it can be nice to have that ongoing prednisone layer, even if it's small doses, as you're able to kind of switch over to a second line agent as needed. So I also, don't mind the dex, but I would prefer the prednisone.
And it really, there's another question here. It's a pediatric question. It says, for pediatric patients who receive a course of steroids, high-dose steroids, for 5 to 7 days, is it necessary to taper off, or can we just discontinue after the course is complete? And I think there's the same problem with stopping quickly. So this slide has just come up. So I'm assuming now that we're actually getting towards the end of the session. So I just wanted to thank everybody so much. I really enjoyed it, and I've certainly learned a lot. I hope that everybody else has learned something from this. It was great to see everybody. And I'd like to thank all of our supporters. Just to say this activity is supported from independent grants from Novartis and Sobi. And thank you very much for participating.